So we are here with Professor Kevin Vernooy from Maastricht, the Netherlands, at the 36th edition of the Giornate Cardiologiche Torinesi. Kevin, thank you very much for being here. It was
Thanks
a pleasure
for having me.
having you here. Your lecture was about conduction system pacing. I will ask you to summarize a bit where do we stand right now in terms of indication to conduction system pacing and tools that we do have to perform this kind of implantations.
Oh, it's already a very big question, of course, but I think it's been a great time actually. We made so much improvements and so much knowledge that we gained in the last couple of years. So where are we now? We see that many physicians have been performing implanting CSP. You know, we are going much faster than any guideline can follow us. Many sites are already implanting it in standard indications. And I think now is really the time that you really have to collaborate everybody together to really include patients in trials and really now change the guideline by showing that CSP is indeed better than RV pacing and can be at least as good at biventricular pacing in heart failure. I think that's really where we stand now, where we have to go for the next years to really show this in clinical trials. Of course, the technique itself has also improved a lot with new guidings, with new tools, new leads, especially all the other products that came along, not only Medtronic anymore, but also the other are now present. So it really gives us much more flexibility, much more opportunities to perform high-level implantations. It's really about now, I think, also besides going to the big trials, really to improve our skills and improve everybody's knowledge on conduction system pacing. I still feel that many sites just start implanting as if it was just a right atrial, right ventricular lead, but it needs much more knowledge to really perform good implantation. So therefore, I think it's really up to this kind of meetings, up this kind of congresses, and even maybe we should have like more courses on really guiding people how to perform careful implantations, knowing where they need to go, knowing where they have conduction system capture, what are all the problems you can encounter during the implantation. I think that's now really what we have to aim for.
Thank you very much. Relevant to this last point, I would like to ask you to delve a bit more regarding the definition of what is left bundle branch pacing compared with left septal pacing, or what else?
That's a great question. It's of course still also a problem because in many patients you really know when you have capture of the conduction system on the left side. And I already say it like this because many times it's not even the left bundle. I think even in 2/3 or even higher, it's actually the vesicle that you're capturing. Especially because many physicians, when they feel a little bit more comfortable, go to the mid-level of the septum rather than very high up at the basis. So then you end up, of course, in the vesicle. Nobody's really looked at that, whether that's actually different from left bundle branch capture. I don't think it might be that different, but we have no real clue, to be honest. So I think that really understanding when you go through the septum, really look at transitions, look at capture beat, look at all the parameters that you can look at to identify where you have left bundle branch capture, that really should be done for every implantation. So we really know, and also just said that during my during my presentation, that we really have to write it down whether we have left bundle branch capture, vesicular capture, LV septum capture. And LV septum capture, just what you refer to, is like a big pile when it means we didn't capture the left bundle or we didn't capture the conduction, but we're somehow deep within the septum. And in the consensus document, we came up with a definition if there's an R prime in V1. But also that is quite,
approximate. Yeah,
approximate. It's quite gray zone. So if you do screwing during the implantation, you nicely see that a small R developing probably halfway the septum, I guess, because nobody really knows. But then there's still a couple of millimeters where we then call it LV septum, and it might be LV septum because you're really deep, just below the conduction or just halfway the septum, and we all put that in one pile, saying it's LV septum capture of LV septum pacing. So I think there's a lot to learn and a lot that we need to study further to better identify what we're actually doing to our patient.
Thank you very much for making this clear. And I would like to ask you also, let's move fast forward 5 years from now. Where do you think we will be at that time in terms of EP community, looking just particularly at the world of high voltage implants? Do you think that we will be performing just ICD with a left bundle pacing?
Yeah, that's a very good question. I'm really curious how those leads will perform and how they will maintain over time. We have seen some previous leads, of course, which became smaller, but at the end we had quite some recalls about those leads. So I'm curious. I think it will really make a difference. But of course, if you put the lead with a shock lead into the septum, there are some limitations. The lead itself, how will it function over time, and not 1-2 years, but 10 to 15 years. The shock coil will probably be a little bit more in the atrium. And the shock coil will also in the valve. Is there any problems with the valve? How is it oversensing of the atrium? Or are we going a little bit more towards mid-apical region through the septum to avoid that? But then, of course, how is conduction system capture at that level? So there's still a lot we need to learn. However, I think it's the way that we need to move forward. So I really love this direction that the companies are taking. But there's still a lot to need to be learned from that. But I think there might be a really good solution if we combine left bundle branch pacing with high voltage shock leads.
Excellent, thank you. Last words for young fellows. I'm thinking about them right now. So a piece of advice for them that are starting right now implanting left bundle pacing.
Yeah. I would really strengthen to use proctoring and to go visit a site that is a high volume implanting site, or even does really know what he or she is doing actually during the implantation, to really see what are all the things that come along during left bundle branch pacing implantations. Because every procedure, last week we had a webinar also, and I also said every procedure is different. Yeah. Every time you learn something new, you see something new, you see something you hadn't seen before, and it even happens after you've done a couple of hundred procedures. So it's really valuable not just to start and think, oh, I read a paper, I will do it myself. Really make sure that you visit the site, you have seen a dozen of implantations, that the biggest issues, the biggest pitfalls that you encountered by seeing it yourself, and then you can take that knowledge into your implanting. I would start off with simple procedures, not heart failure, bradycardia implantations, and maybe even when I
like
did it,
6 sinus
maybe even that, to really start that the patient is not dependent on that. But even AV block he can do, but it's really trying to understand before you just start doing it. And even the first case, it would be really nice to have somebody in the operation room who knows much more than you, who can guide you a bit during the implantation. I think that's, you see that often with new products when they are launched by the industry, then it's very carefully held.
Yeah.
Then but it also, they guide you through the implantation. And now it seems like this bottom up, all the physicians like this, they all started. Yeah. And I think we can do a better job and even improve the technology and improve the skills if we just have a careful educational program actually for people who are starting new in the field.
Lovely. Thank you very much for being here again and for your time during this interview. Thank you very much.
Thank you so much.
Thanks, Kevin.
It was great having me.